My name is Dr. Mark Lachs. I run the Division of Geriatrics and Palliative Medicine with this gentleman, Dr. Ron Adelman, and thanks for coming to our lovely Belfer building. Before I introduce the senator, who will introduce the panel, I just wanted to let folks know about a wonderful new recruit we've brought to Weill Cornell Medicine, a woman by the name of Sarah Saja, who is the world's expert in aging and technology. She came from the University of Miami as a computer scientist and a psychologist, just a wonderful gerontologist. And I'm bringing this to your attention because she's conducting a number of interesting studies which might interest you. There's some informational material on the table in front. One study looks at getting older adults to exercise and how to incentivize them. There's another study that looks at patients with mild cognitive impairment or early Alzheimer's disease, or the people who love them. And this is an intervention to try and help the caregiver and the patient using a laptop and Wi-Fi sort of interventions. You get to keep the laptop, so if you know of someone, and you get free Wi-Fi service during this, and many of these research projects include compensation. And then finally, Sarah's been very interested in financial vulnerability of older people, people who have been fleeced by various economic scams. I know the senator's been interested in protecting the finances of older adults, and she's trying to get at why some people are vulnerable and some aren't. So on your way out, if you just take a look at some of these flyers, they look like this, and there's information on who to contact. So with that predicate, I want to introduce the senator. Senator Liz Krueger is a friend, and I cannot thank you enough and your team for co-hosting this event with us. Liz has represented this district for some time and is a wonderful friend of the medical center, but for Ron and I, is a wonderful friend of older adults, deeply devoted to the issues of aging, housing, and all kinds of related issues. I'm just guessing that she might be excited to serve in the new Senate, the new Democratic Senate. I'm just guessing, okay? Yeah. And so without further ado, my friend Liz Krueger.
Thank you so much, Doctor. Hi, everybody. So better than the snowstorm last time, right? So thank you all for being here. Hi, how are you? So we are going to repeat in the spring, by the way, the document section, which a lot of you couldn't come to because of the snowstorm. And so just trying to, this has been so successful, and I think so much important information that I do think we will probably do continued events like this again in the spring when the weather gets warmer again. So I also want to thank Weill Cornell for partnering with us and providing this terrific space. I see Dr. Rabbi Schoolman, who first brought the proposal to my office's attention. So thank you so much, Rabbi, for suggesting we do this. And we're really thrilled with how many great presenters we've had. As I said, we're going to continue to work with Weill Cornell to co-sponsor other later life planning series in the spring. We have index cards that you might have gotten when you walked in, and if not, you raise your hand, we'll bring them to you. So if you have questions to ask, we'll collect those cards, and then we'll do a Q&A at the end. We have a really terrific group of experts tonight. Dr. Adelman or Adelman? Either way. What do you prefer? Adelman, thank you. You know, we had this discussion at the office because Adelman's often with an E, but okay. So Adelman, co-chief of the Division of Geriatrics and Palliative Medicine at Weill Cornell, and also Dr. Diamond on Palliative Care, the chaplain here, right? Jean Walsh is the chaplain at this facility?
Yes. Or with this team.
Fine, with this team. Thank you. And we also have Elizabeth Schack, who's the Palliative Care consultant. And nurse practitioner, thank you. Yes, that's what the NP, see? And you have the program with their bios, so anything I've messed up, all the actual facts are in print for you. And I'm really just gonna turn it over, but I also wanna say, I think of all the kinds of presentations, my incredible staff, Wendy Brennan, standing there at the back door, has helped put together for me. Getting people to understand about palliative care and hospice is perhaps some of the most important, because I find when I talk to people, there's so much misinformation about that. One, people assume palliative care is just something to drug you until you die, and that is certainly not true. And they also don't realize what hospice care is, and I've known what hospice care is for a long time, but in the last, I guess, 2 years, I had both of my parents in hospice care at their home, actually for quite a while together. It was an interesting group scene for us, but it was an amazing set of services that were available to both of my parents and to our family who were there surrounding them. We're a very invasive family, so literally it was all of us there all the time for the good and the bad of it. So including a musical therapist from hospice who thought she was coming to, I think, sing with my father because he loved music. But all the great-grandchildren would hang out and everybody would dance together. And I'm not sure if that happens too often in a hospice setting, but our day was, the guitar playing hospice expert is coming and we're all going to dance, like 4 generations. So hospice can be an amazing set of services and programs in a period of time that often people just think of as all negatives, but it doesn't have to be. So with that, and from my own experience of how important the work you all do is, I'd like to introduce and lead the program, Dr. Adelman. Thank you. Thank you.
Good evening. We're really delighted to be here this evening with you. Our objectives this evening are to clarify what palliative care is and what hospice is through an actual patient story. There's a great deal of confusion about these terms, as Senator Krueger mentioned, and we really applaud Senator Krueger for developing this forum. Happily, we have part of our New York-Presbyterian Weill Cornell Interdisciplinary Palliative Care team with us this evening to illustrate really how palliative care works, how each discipline has a role, and how we interact together. And we'll give you an actual case, a patient story, so you can understand the context of our interdisciplinary roles. And now each of us will introduce ourselves and tell you how we were motivated to choose palliative care. But before that, we're going to have Dr. Randi Diamond start by defining what palliative care is.
I know we have 1 or 2 slides to show you, but I don't know how we can access those slides.
I will work on that.
Yes, I think that would be really helpful. I think I just wanted to start by saying I'm Randi Diamond, and I'm one of the physicians on the palliative care team. And we all will be introducing ourselves, but one of the things that we wanted to each share with you was how we came to do this work and why we are passionate about this work. And so I will just start by saying that, I came from a background of being in geriatrics and taking care of older adults. And I realized over the years of doing that a lot of what I was doing was related to communication and talking with my patients about how they wanted their days and weeks and years, as they were older to be, and to plan for how they wanted their lives to be. And that sort of brought me into the world of palliative care. And now I do inpatient palliative care consultation. And one of the most frequent questions I get from people is, why would you want to do that kind of work? And invariably I tell people that I love the work that I do. It's a privilege for me to be able to get to know patients and families as well as I have the opportunity to do, and it's incredibly rewarding work. So with that, I will now start to just talk a little bit about palliative care.
Slide is up. The first slide.
Yeah, so as you can see on that slide, palliative care is really all over the news. It's in some ways it's hard to miss, whether it's in the New York Times or it's in medical journals or whether it's in Consumer Reports. Is one of those things that had a whole story on what is palliative care. Or many of you may have heard of the book Being Mortal by Atul Gawande. Another, book that really talks about both geriatrics and palliative care. And so it's very much in the public discussion, and yet, there are still, some misunderstandings about what it really is. Can we go to the next slide?
The next slide is up.
We talk about palliative care being this sort of umbrella of specialized medical care that is provided by a team, an interdisciplinary team. As you can see, my colleagues up here, we have our chaplain, we have a nurse practitioner, we also work with social workers all the time, and we all are there to work together with your primary doctors, and we help to take care of patients when you have serious illness that can be both physically and emotionally stressful for patients and for their families. And so we're a team that sort of provides holistic care for patients and families all together. So the patient and the family is just as much a part of the team as we are. And when I talk about, serious illness, it's really that we take care of people no matter what the illness is. It's not just cancer. It can be heart disease, or it can be lung disease, or it can be kidney disease. And it doesn't have to be something that is a terminal illness, but it can be a serious illness. And when people have a serious illness, a lot of times they have symptoms like pain or trouble breathing, that may be related to their illness or could be related to the treatments for their illness. And so we're here to help with symptoms, right alongside of the treatment that you're getting for the other illness.
Quality of life.
Yeah, I can't see what's up there. I mean, really our focus is on helping to optimize your quality of life. And that's different for every person and every family. And so, our ability to listen to what you are telling us about what makes quality of life for you is very key to what we do. I think there's another slide here that I can't even see what's on there. This is just about it being the interdisciplinary team. And really, I think it's a team that works very well, hand in hand, together and with you and with your regular doctors.
Okay. So now I think what we'll do is just go through the rest of our panel. So Jean, maybe you could mention a little bit about what brought you to be in palliative care?
Yeah. So my name is Jean. It's great to be here this evening. I don't live in this district, but it's close to be here and fun to be here for me. I'll just mention a couple of things. I've had probably the closest people in my life be struck with very, very serious illness. My mom when I was a teenager, and then my spouse just a few years ago. And so accompanying them throughout the journey of their illness and feeling its impact on myself and seeing the impact on my whole family is something that I think changed me forever. and I think gave me an empathy and a knowledge that I never wanted, but because of those experiences give me an opportunity to work with other people in tough situations. So I just want to say what a chaplain is, because of the folks on the panel, it might be that you've had less experience with a chaplain. So I serve as a multi-faith chaplain. Chaplains that work in a hospital, we need to have graduate degrees, and then we also need to have 2 to 3 years of clinical supervision before we can be hired. We work with people of all faiths and people who perhaps do not feel that they have a quote-unquote faith, but everybody has something that's sacred to them, and my role on the team, with the team, is to really try to look at what it is that's sacred and how to preserve it all the way through the illness. And one story that I just want to share briefly, in working with a particular patient who really, she didn't have a particular religious or faith tradition, but she had some very important ideas about how she saw her end of life and what she was looking forward to. Forward, not like wanting, but forward as far as what her future might be. And she talked about returning to the earth. And so in my time with her, I was able to find an Alice Walker poem that really talked about blessed are those that can imagine themselves as a blade of grass, because they will be forever grateful. And that really, really resonated with her. And it's in that match of working with patients that gives me passion every day.
My name is Beth Schack, and I'm a nurse practitioner. I just wanted to, some people might know what nurse practitioners are, but we're registered nurses with a little extra education and a master's degree. And usually we have a specialty, and my specialty is geriatrics and palliative medicine. I had the privilege of being hired by Dr. Adelman about 13 years ago with minimal experience as a nurse practitioner to be part of a team in the hospital setting to actually start the palliative care consult team. I currently work one day in the hospital and a few other days in what we call our outpatient setting or in clinics. I feel that my passion for palliative care really comes from the relationships that I encounter and are honored to be a part of. I think hearing the stories and meeting patients where they're at is really where my passion comes from.
Okay, so thank you. And now what we're going to do is tell you about a patient, and I'm going to read sections of her history, and then our various panelists will respond to the context of what they were experiencing and how we intervened as a team. So Angela is a 72-year-old woman with asthma and emphysema, and in 2015, she was diagnosed with lung cancer. Angela's oncologist referred her to the outpatient palliative care team to help manage her physical, emotional, and spiritual symptoms. The palliative care team collaborated with Angela's primary oncologist from the time of the referral until their last visit. A very independent and active woman, Angela opted for treatment with standard chemotherapy, immunotherapy, and radiation. While tolerating the treatment as well as could be expected, she experienced significant symptoms, including a cough related to radiation, nerve tingling, numbness, and pain on her legs related to the chemotherapy. Angela reported that she was feeling anxious about her diagnosis and symptoms.
So usually one of the first things that our team does when we meet patients is not only introduce ourselves, but we really actually explore patients' physical, emotional, and spiritual symptoms. So in my journey with meeting Angela, one of my roles was to really help her with her physical symptoms in the moment. So Angela was really a very social person. She was really loved by everyone. So when I met her, she really described her life as a very busy life, full of many things that she loved to do. She highlighted that she enjoyed her relationship with her grandchildren. She loved to spend time with a lot of her cousins that she was very close with and friends. And she actually had a huge role as one of the main volunteers in one of our outpatient pavilions as a volunteer. So she spent a lot of time with patients that had cancer. And so she was really surprised that now she had this diagnosis herself. She described that the two symptoms, like Dr. Adelman was talking about, was this pain, which we call nerve pain in her legs, that was really causing her to have trouble walking and being able to get around and do the things that she loved to do. And then on top of that, some of the radiation symptoms was this cough that really made her embarrassed about going places because she felt like she couldn't control it sometimes. And you know, she liked to go to the movies and things that maybe was more of a quiet place for her. So the cough and sometimes a related difficulty breathing or shortness of breath that came along with that. So Angela was very firm that taking pills was not her cup of tea. So our negotiating with Angela to try and figure out how to manage her symptoms with maybe some traditional medicines was challenging. So after, you know, a lot of discussions, she agreed to take, kind of these medications, cough syrups, which she felt comfortable taking kind of, as we call it, standing or around the clock to hopefully decrease some of the cough. She felt comfortable taking honey and some home remedies that she used. She decided that she'd be comfortable working with respiratory and physical therapy to work on some breathing techniques, and also some exercises to maybe help her with her leg pain. And then in addition, we talked about she was not keen on really starting any pain medications. She had a brother that had an addiction issue, and she felt that for her was really important to kind of be aware of that. So we decided on a nerve pain medication or nerve agent that we used, a medicine that we use typically with nerve pain, and that actually really worked. And it actually happened that there's been studies on this medication that actually has associated a decrease in cough. So we used one medication and some other syrups and home remedies and non-traditional medicines that were really helpful, I think, that to reduce her the symptoms that she was experiencing.
And Beth, did she interact with our social worker too?
Right. So unfortunately, our social worker isn't here to really describe her role. So obviously, our team is it's so important to have a social worker on our team. They really serve as a person that makes sure that services and interventions take account of the whole person and their family, whatever that means to them. Our social worker also played a critical role in all of our patients, but in particular with Angela, about providing counseling and support to her and her family. So Angela really struggled with anxiety at baseline, and so with her new diagnosis and the symptoms that were really changing her life, her normal life, she was really trying to figure out how to manage and cope with this. So our social worker worked really hard on trying to explore with her how she could manage the anxiety, and worked with her with talk therapy and support to guide her and how to work on these things. And I think it was very helpful.
Thank you. And I'm going to continue reading the story of her case. Over the course of Angela's outpatient visits, the palliative care team learned that the patient's husband had died some years ago and that she had continued living in her home in Westchester. Angela remained active, doing errands and working in her garden, which she enjoyed. Angela did not socialize much, but reported having some friends. She was very close to her son and daughter-in-law and 2 granddaughters. The palliative care team also learned that in the earlier part of Angela's life, she became part of the religious order of the Catholic Church as a nun. After a few years, Angela decided to leave the order and began working for a talent agency in Manhattan. Angela described herself as a spiritual person and had strong faith in God. Angela felt prayer was a helpful tool to her in her daily life and had helped her cope with her cancer diagnosis.
So I just want to speak a little bit about some of my work with Angela. And as I said before, so much depends on what is very important to the person. And in Angela's case, she really had a very strong spiritual core. So much like we learned that she had decided to join a Catholic religious order, and then made a decision to leave and pursue a whole other path. So that's a pretty big thing, and especially when faced with illness, that is a good opportunity to kind of explore with somebody paths chosen, paths not chosen. So I used this opportunity as kind of doing a life review with Angela and asking her to reflect on where she was when she made those choices, what first drew her into the community of religious life, and then what drew her to a life with her husband and have a son. And she was able to see, even though there were different paths, that there were deeply common values that she had in each place, which was really important for her to be able to see. And it also gave us an opportunity to reflect on the relationship with her granddaughters, who were 7 and 11, and how important that was to her. And one of the things as a multi-faith chaplain, as much as I might help people reflect on the past, but then you always bring it back to the moment, because this is what they're experiencing now. So reflecting on what she had learned from life about her choices and what she had learned about her relationship with who she referred to as God. And it just really gave her an opportunity to affirm herself and to affirm the choices that she made, and to know that she was deeply rooted in this whole journey. And I just want to mention one thing. We knew that for Angela, prayer was important. And so I always, when I work with patients, I always ask them, would you like me to say a prayer for you, or do you want me to hold you in my heart? Because then I give them a choice, right? They can, an easy in or an easy out. And then if they do want to pray, and in the case with Angela, I would always ask, well, what do you want to pray for today? Because that also gave me just an insight into what was most important in her heart. And it might not be anything that I would have thought that it was, but it gives me a clue, and then it gives us as a team that much more insight to who she is as a person.
And I just wanted to add to that, as a physician, and I would guess also, our nurses also, I mean, we don't normally ask patients about prayer, and yet I find that when I'm seeing a patient alongside of Jean, and we often see patients together, I learn so much about the person that we're visiting with, and so much about what's important and how they answer your question about what they want you to pray for. It's often a great window into their values and their hopes and their fears.
So 3 years after Angela's diagnosis, and after 2 years of a good quality of life, the cancer unfortunately spread to Angela's bones, which created severe pain, and she required hospitalization. During Angela's hospitalization, our palliative care inpatient team was able to follow her along with the inpatient oncology team, taking care of her to assist with aggressive management of her symptoms. In the face of the news that her cancer came back, the inpatient palliative care team provided emotional and spiritual support. Angela was seen regularly by our inpatient palliative care team, including our chaplain and social worker, in addition to our nurse practitioner and physician. Our team further explored her symptoms and her faith practices.
As I said before, some of our expertise is really in managing symptoms, assessing symptoms and managing symptoms. And when we're assessing symptoms, in this case, her pain, we really also are interested in how that pain is affecting Angela's life. and what it is that's limited in her activities, and what it is that's changing about her ability to function the way she wants to function, and also whether what she's thinking about what these symptoms mean to her. So for Angela, she now had this new kind of pain that was more severe than she had been having as an outpatient. And, you heard before that she had some reservations about taking pain medications, related to her family history. And so we needed to talk about that some more because now her pain had gotten so severe that the pain medications for the nerve pain weren't doing the job for her. And we needed to talk about at least trying to use some opioid medications that could help relieve the pain and get her back to like being able to do, some of the basic things in her life that were important to her. And so with a lot of discussion and with information that we, had gotten, from what the outpatient team knew about her, we were able to continue to address her concerns at the same time that we were trying to help her with her pain. And so we started some very low dose opioid pain medicines. And when people take opioid pain medicines, you always have to worry that they're going to cause constipation. So we also had to address, how we were going to prevent that from happening. And then when she started to take the medicines, she also complained that the medicines started to make her feel a little nauseated. And so we had to talk about the fact that that was a side effect that probably would go away after a few days. But in the meantime, we would help with anti-nausea medicines to help get her over that hump so that we weren't making her even more miserable with treating her pain and making her be able to tolerate these medicines so she could get back to being more functional. And then we also started to explore with her what she was worried about, what this pain meant. And, pain is physical pain, but in palliative care, we talk about total pain. And total pain can be not just physical, but it can be emotional and psychosocial and spiritual. And when you hear that you have pain because you now have cancer in another part of your body, that can bring on a lot of pain that's not physical and worry that's not physical. And so that's something that we, also address.
So I just wanted to speak a little bit to that, kind of the existential pain and the spiritual pain, which, again, I feel like everybody on our team plays a role in that because of our training. But I want to say that especially social workers and myself as chaplain, that's really an area that we try to delve into with people. And I remember going with the medical team. I remember going with the medical team and they would ask, well, how would you rate your physical pain right now? And then one time I said, well, how about your spiritual pain? And the person just opened up. And in Angela's case, I just want to say that even with a faith in God and a strong, just a strong faith, it's always hard to find out that the cancer's growing, and it brings up fears, like Randi mentioned. It brings up questions about God, if you believe in God, or about the universe, or how can this be happening to me? And there's one of the things that's hard is that we can't fix these big deep pains for people, but what we can do is provide a safe space for them to talk about it. We can allow Angela to talk about her fears about not living to see her grandchildren grow up. And we can sit with people and really take the time to hear what they say. And sometimes just being with people helps to ease that pain. So I think that that's also another part, an important part of what we all do.
With the new information about Angela's cancer and choices to be made about her future treatment, the inpatient palliative care team suggested a family meeting with Angela, her son, her oncologist, and her primary hospital team. It was important to discuss realistic expectations, possible treatment options, what was most important to Angela about her life and her illness, and what trade-offs Angela might be willing or unwilling to make for further treatment.
If we could go to the next slide, I think it might be good to look at this. You know, one of the most important roles that we play in palliative care is really to facilitate communication. And that's communication between patients and healthcare providers, but also between patients and their family members, and between the different medical teams who are taking care of patients. And, you know, as the palliative care team, we don't ever have an agenda when we come to see a patient. Our agenda really is to be there to listen to the patient and the family and to hear what's important to you. And to hear what you're thinking, what you're understanding, what you're concerned about, what you're hoping for, what you're worried about. And in the hospital, like Angela was, you get bombarded with information. There's new teams that come in every hour of the day almost, telling you more medical information. And that's overwhelming. That's overwhelming for anyone. And so one of the jobs that we try to embrace is that we help patients and families navigate all of that information, exploring what is it that Angela understood about what the doctors had said to her about her cancer, and making sure that Angela and her family got the information, understood the information, didn't still have questions about the information, and when you're facing now the reality that the cancer has spread, the idea of, well, what's next? And what are the options? And, sometimes there's more than one option that gets presented to you, and making sure that Angela understood what her choices were and what making each of those choices might mean for her. And because our outpatient team had talked a lot with Angela to begin with, we kind of had somewhere to jump off from. So it wasn't like we were total strangers walking into the room, because, we could say, oh, we know you've been meeting with Beth, and she's shared with us, that you've talked about these other things, about her, say, her granddaughters, or about her gardening, and what's important to you. And so it gives us a basis to be able to continue the communication and to help patients like Angela also be able to share in a helpful way with their family members key information.
Yeah, no, and often we will create a meeting where if there are questions about what is going on with the cancer and what the treatment options are, we'll bring the oncologist back to the meeting with us to go over things another time or two, because sometimes it's really hard to understand the medical jargon and the medical language, and we're often interpreters and make the other disciplines come back to go over things in ways that people really understand.
Yeah, I think sometimes even, as we're sitting in those meetings, we may be the one to ask the question that a patient might ask, because, as healthcare providers, sometimes we get caught up in speaking medicalese and, medical terms, and sometimes it's just a basic question, that it hasn't really come across clearly. And while we, as the inpatient palliative care team, may not have like a long-standing relationship with a patient like Angela, even though our outpatient team has. It's actually remarkable how quickly we are able to develop a rapport and really a deep relationship at a time when things are really so fraught and so vulnerable.
And at the family meeting, Angela spoke about her wish to continue active treatment for as long as her quality of life was acceptable. The palliative care team explored with Angela what an acceptable quality of life looked like, what it meant to her, such as living arrangements and family relationships. Angela expressed during the family meeting that she hoped to travel back to her hometown, San Diego, California, to see family and old friends. The palliative care team encouraged her to go and promised to work with her and her family and her oncologist on a regimen to manage her symptoms well enough to allow her to travel. Angela also named her son as her healthcare agent to make decisions for her if or when there came a time when she was no longer able to do so. Angela gave clear instructions to her family and her providers that despite her decisions to continue therapy and treatment, that she would never want to suffer or be kept alive on machines.
So over the years that I was getting to know Angela, I also got to know her son and daughter-in-law, and her daughter-in-law was a nurse actually in our hospital. And Angela felt very comfortable talking about her end-of-life wishes with her daughter-in-law, our team, and the oncologist, but really struggled to share the information in detail with her son throughout kind of these first couple years of her diagnosis. She told us that she felt that it would scare him and make him more nervous than he already was about where she was at in her disease trajectory. With encouragement and over time, just like Dr. Adelman said, she was really able to detail more about what her wishes were, including wanting a more natural death, not wanting to suffer, that tubes and machines were not acceptable to her. She was able to complete her living will with more of those details, so her family, her son, and her daughter-in-law didn't have to guess. And I think she really felt that she wanted to really be able to share this information with her granddaughters. Even though that they were really young, she wanted to leave them a legacy of her life so that they would remember her the way she wanted to be remembered. So our team was able to get one of our great services, Child Life Services, involved to be able to guide Angela in how to communicate this with her grandchildren. They also gave her some tools in leaving this amazing, just a legacy piece of her life that she was able to share with them that was really, really meaningful.
I just wanted to add that, I think when she was able to do that, it's really such a gift to her family, because when families, get to a point where they suddenly have to make a decision about their loved one, if you don't know really what that person wanted and you haven't had those conversations, then it's a real burden on the family. And I think most people feel like they don't really want to burden their children. And so it really is a gift to be able to have these conversations and unburden them.
And I would say maybe it's also a responsibility and an obligation when you do appoint someone to be your healthcare agent or healthcare proxy, they need to know what you want. I mean, you need to have discussions, so it's your wishes that are being carried out, not the wishes of your healthcare proxy. So without a discussion about what your wishes really are, your wishes might not be fulfilled. So, and we don't do very well in America about these kinds of discussions, but this is an important part of communication, etiquette, and responsibility that we have to bring more into our American lives. I think I'll finish the case. The palliative care team then introduced the concept of hospice care so Angela and her family would understand what was available in the future and begin to think about when the transition from palliative care to hospice care might become appropriate. Angela and her family were appreciative of the support and information about hospice. The plan is for Angela to follow up with outpatient palliative care when she returns from her trip. And now Dr. Diamond will discuss a bit more about hospice and its connection to palliative care.
Could we advance the slide again?
I'll try.
There. So, I think a lot of times people think that hospice and palliative care are the same thing. I mean, we hear that a lot from people. And there are, many, many similarities. They're both holistic care provided by, multiple disciplines. And it's care for both, patients and their families. But hospice care is actually just one piece of palliative care. As you can see in that diagram, palliative care is sort of a broader kind of care that can take place earlier in the disease process. Hospice care is really intended for people who are expected to live 6 months or less. Now, I know that may sound like a surprising number because I think a lot of people think of hospice as for the last days or weeks of someone's life, but really it's intended for people who the expectation is probably 6 months or less. And hospice care is really a philosophy of care. And it can be provided in different settings. As the senators told us, it can be care that's delivered at home. And it sounded like that was an amazing, family experience, taking care of her parents and the whole family. Not every family can manage their loved one at home. It sometimes depends on how many symptoms or how severe the symptoms that a patient is having and what it takes to control those symptoms. And also the amount of care that actually gets provided by the hospice agencies is not that much. So a lot of the burden of caring for the patient does fall to the family. And so some families are able to do that and some are not. And it's not a reflection really of willingness. I mean, I can tell you from personal experience, and I have experience in palliative care, that my family wasn't able to handle it at home. So it's really, even with experience, sometimes you can't do that. And it's really a very individual decision for each family, whether it's something that you can do. It's not a failure if you can't do it at home. Sometimes the patient is more comfortable in an institution rather than at home, and other patients may say the most important thing is to be at home.
Yeah, it's a very individual preference, and often we have very stressed caregivers after long illnesses and a long hospitalization where the caregiver is exhausted and they really can't be expected to continue giving care. In fact, what they need is a chance to have some respite and to focus more on the emotional relationship with the patient rather than taking on extensive caregiving responsibilities. So any other comments from our panel?
I was just going to say that I think some of the common themes that we've heard about palliative care is just kind of hoping to hold up what's sacred and really helping to make sure that people live and really live as long as they can. And one of the things that our team is also very aware of, when we've talked about listening and getting to know people, that there are people from different cultures, there are people from different religious groups, and that, you know, the eyes, sometimes we say, you know, I'm not even aware that I have eyeglasses on because I'm just so used to seeing the perspective that I see. But it's very important, especially in serious illness and end of life, to really know kind of whether or not, sometimes it's the emphasis on the individual. Sometimes the emphasis is really on the collective. And those are very important things for our team to be aware of, when we're working with a Muslim patient and their family, or if we're working with any of the different traditions within the Jewish religion. We've arranged at times in working with a Buddhist patient that the hospital has then respected a ritual of 8 hours of chanting in the hospital after a death, to really just respect that. There are just so many important pieces, and our part of that is to make sure that those pieces are heard and respected.
Beth, do you have anything you'd like to add?
No, I think they
Okay.
I'll leave some of my comments for the question period.
Sure. I would just like to say that one of the mistakes we see and hear is that palliative care equals end-of-life care, and it doesn't. Sometimes it can, but you can imagine someone being treated for cancer, having horrible symptoms of nausea, let's say, and some pain. Very often we'll treat the patient from those symptoms, and hopefully they'll have 30 more years of life with successful treatment. So palliative care is coming to help someone who's having a serious illness, and hopefully they get better. The other thing that we try to do in both palliative care and in hospice care is to humanize the experience. So if you're in the hospital, I mean, I know when my father died, this is what motivated me to actually get involved in palliative care. This was about 13 years ago, and he was in a Boston hospital, and really people were very inexperienced in handling pain. And my father was very gallant and very aware that he was dying, and heroic, probably the most heroic part of his life. So it showed me that end of life can be a kind of illuminating time as well. And in my father's case, his acceptance of where he was remarkable. And my role was to make sure his death was humanized, so that there was a private room. There could be a practice of the sacred in his time left on earth. And so we really tried to bring humanism and a kind of normal life world back to a patient who might be in a hospital world, which is not exactly soothing and comforting. But I think what we'd like to do is open up the floor to your questions, and we look forward to this part. Yes? Oh.
So Dr. Allen, I'm going to leave this up to you. If you want to have people just raise their hand.
I think raising hands is good, don't you?
Everyone has cards. I think it's a little bit more organic if people
Should we bring the microphone to the person now? Yes, so that we can hear. Okay.
I don't have cards.
No, that's all right. We're
Just ask.
Clearly, you talked about your inpatient and outpatient palliative care teams, but it's all related to this one hospital. My question, since my MS care is at a different hospital, does every hospital in New York have outpatient only in some cases inpatient?
So outpatient palliative care services are much more limited than inpatient services. Over the last decade, inpatient palliative care has really, spread to most hospitals now. I think there's a growing effort in all hospitals to have outpatient palliative care, but it's not there yet. It's coming.
I mean, most hospitals that have over 300 beds have palliative care inpatient consultation services. And as Randi was saying, more and more we see, and hospitals get it, that the sooner you provide palliative care and other options for people who have very serious illness, they often don't want to choose to be more aggressive at the end of life. They don't want to die in an ICU. I mean, 20% of Americans die in intensive care units. Most people want to die at home. And so the idea is the sooner you involve patients with discussions of goals of care and help them get what they want in terms of care choices, they'll probably go to hospice earlier and have a better end of life if they're at that point. I mean, in New York State, we have the worst referral rate to hospice, I think, in America. And it's often people are referred at the last 3 or 4 days of life, and the family and the patient don't get the benefit of hospice if you don't have more time with hospice in their services. So this pushing into outpatient palliative care is a good thing, and I think that's the trend at this point.
I may have missed this. It's very elementary, but what does the word palliative mean?
Can you repeat that with the microphone?
What does the word palliative mean?
I think in the Latin, it means a cloak. It's cloaking and shepherding a patient through difficulty.
Yes, for patients that don't have family, what are the unique challenges both to the patient as well as to the palliative team?
I think that's something that we unfortunately face more often than we would like to. And I think we always make an effort to explore with patients who their family may be, which may not be, blood relations, but people's families can be, close friends or even maybe not so close friends, but someone that is willing to be there for that particular patient. And I feel like we often, with social work in the hospital, really will go to extraordinary lengths to try to help find someone that's connected to a patient, because it's very difficult when you have someone, who is there's a term in medicine that we even talk about as being unbefriended, and that's really very, very, challenging.
And in the outpatient world, it's really a big focus in outpatient geriatrics, for example, when someone might be having cognitive difficulties in the early phase, we need to find someone, either a relative or friend, who can really follow what the patient's wishes might be. And sometimes you need to get a different kind of agent, an institutional proxy, guardian, or whatever, because the worst thing is to be in the hospital and not to have directions. People are often waiting for court decisions and die while waiting, and not what they want. But, this is, we have a very aging demographic, and more we're coming across people who really haven't made these decisions. And so,
And we've actually had, even sometimes someone's doorman will step up and be that person.
Hi, I'm a medical student at Cornell, and as a medical student, I have a particular interest in how families make decisions about healthcare decisions, whether it's in pediatrics with like an adolescent patient coming into their own adulthood, but not being legally able to make their own healthcare decisions, or if it's in palliative care or hospice care, or really anything in between. I just like to see how families work. But I'm wondering if you could talk about how you mitigate the difficulties that you come across when families disagree about what should happen, what is right for the patient, what is right for the family, because if someone is losing their life, they're also, I guess, exiting other people's lives as well. And so how do you deal with that? What resources do you use?
Yeah.
I can just share my, oh, okay. I can share my experience, and I work in the palliative care team and also on the medical intensive care unit. And I think, and as a chaplain, I have been involved in conversations to try to help facilitate family members talking to one another about differences. And obviously that's the most ideal if people can come to an agreement. But if they cannot come to an agreement, one of the things that they have to live with their decisions forever. And that is incredibly important, and incredibly important to, the ongoing reality of that family. And so, at some point, it's as much as possible the family finding some peace and maintaining a sense of unity around that, as opposed to if there might be a particular decision that two people feel this way, three people feel that way, of really trying the most that people can really come to agreement with, to be able to live on in that family reality. So that's one thing I would say.
I think, that's sometimes we will have more than one family meeting to try to bring everyone together. And our role may be just to listen to each family member and maybe help them realize that maybe they're not going to agree, but that they have to live with the decision that's made and, help them come to terms with that.
yes.
I've just gone through surgery at another hospital, and I think buying a sweater at Bloomingdale's gets more attention from the medical administrative staff than the patient does. Oh. If the issue is not life-threatening, where you're really seeking out your kindness and support and understanding, if it's up a degree, lesser of seriousness, should or can the patient look to a team like yours in other medical facilities, or is your program and system in place only for those that are one step away from the grave, so to speak?
I think mostly we deal with serious illness, but how we define serious is very dependent on the patient and what their experiences with the medical personnel. I would say generally most hospitals have patient services where if you're not getting the attention you require, or you're dissatisfied with the care, you would call, and even in our hospital, we have a patient services representative who would kind of deal with things first. Oh, wow.
It's terrible. So it is, it's really
Wow.
But so I asked for your kinds of services, and it's just startling. So that your program here, and I
Yeah, that's correct. You need to be a patient in the system. Yeah, right.
And a big part of the reason for that is that very key to palliative care is being able to work with your other doctors. And so if your other doctors are in another system, we don't have the ability to really work with them in the same close way.
Is there a service edge work that you described that's available in a private sector? Have private doctors and caregivers and chaplains formed a private corporation that is available to?
I think that's coming. I'm not aware of any. There may be, but I do think I've heard discussions about things like that.
Other questions? Yes.
So while I'm walking, I'm going to take a prerogative and ask a follow-up on something, Dr. Adelman, you raised. You said Americans should talk about this, more openly earlier. What do you think the medical profession can do to get that conversation started, and what can we do?
I think we need to discuss advanced directives. I mean, your doctor should be able to hold a conversation with you and you talk about what your wishes are. They can change. Nothing is without the possibility of change, but to discuss what decisions you need to make in advance. Do you want to be resuscitated? What would the circumstances of your being put on a ventilator be, and understanding those kinds of issues? Because your doctor really is there as your advocate. I mean, I tend to know what my patients want, and I'm there to really, I assume their healthcare proxy will fulfill what their wishes are, but I, as their doctor, know what they want, and I will advocate and fight for what wishes they really express to me. That's my job, to make sure that we listen to those directives. And now there's a history of maybe not paying attention as fully to advanced directives as we should, but I think that culture is changing. So I think we have to just face the music. I think the taboo about not talking about death and dying is pretty major in our society, but the best way is to begin having conversations. They don't have to be conclusive, but it's creating a rapport with your health provider about what your wishes might be or what your questions are about what you should consider.
And that discussion with your families as well.
Yeah, the healthcare proxy, people identify someone who will actually make the decisions for them without having conversations about what you really want. And so they're left. In the case we presented of Angela, she was really able to explicitly tell her son what she wanted, and that took anxiety from the son and allowed him to feel good about, what he was deciding upon, because it was his mother's wishes, which it should be. But so we don't do very well with these difficult conversations, but we need to change the culture. We really do.
Am I figuring that not every hospital has a palliative or hospice section physically in it or administratively in it?
Every hospital, it seems, in America that has at least 300 beds seems to have a palliative care consultation service. Hospice isn't necessarily in each hospital. At NewYork-Presbyterian, Weill, Cornell, and Columbia, NewYork-Presbyterian, they do have some hospice beds available, but this is a new culture as well, being able to accommodate end-of-life patients with hospice in hospitals. But So that's going to be variable about the availability of hospice in the hospital, but palliative care services in larger hospitals should be part and parcel of what is offered.
How does a patient order palliative care from home or in the hospital with their insurance problems to be able to know what's going to be ordered, referred, and covered?
Well, here at New York-Presbyterian, really, a patient can request a palliative care consult if they're in the hospital. Or if they're an outpatient, they can ask their oncologist or their pulmonologist or whoever it is, their doctor that's taking care of their serious illness. You know, you can say, I really would like to be referred to palliative care. In our experience, when patients or families ask for it, their doctors usually will say, fine. On occasion, there may be some pushback, and I think, that comes, I think, also from the need for greater education, even of medical professionals, about what palliative care is. And, there's still a lot of misunderstanding among physicians as well. But patients and families can absolutely say, I want these people involved, please call them.
And insurance generally is fine and acceptable for palliative care. Hospice benefits, though, are variable according to what insurance you have. Beth, do you want to mention that a little about?
About the
hospice?
Yeah, it's a Medicare benefit, but some of the agencies vary. So usually case managers and social workers, either in the community or in the hospital or outpatient setting and in the hospital settings, can kind of help patients and families figure out what might be available depending on insurance benefits. The home piece is challenging. There are very limited to none palliative care-based home programs. I think this is another thing when we're talking about future planning. It's in the process of being planned. I think that this also relates to insurance coverage and hopefully insurance companies changing their policies in order to incorporate these essential programs. So I think that this is in the works both on a government level and making some changes.
I'll touch on one. Oh, yes.
Well, first of all, this isn't our whole team. We have more folks that are not with us this evening. We have a number of other nurse practitioners. We also have other social workers that aren't here this evening. So on a daily basis, I don't know, how many folks might we see?
It varies, and yes, there are days when it can feel overwhelming, but we do our best to try to see as many of the patients as we can, and try to prioritize, if someone really needs to be seen more urgently. But, we see, many hundreds of patients a year.
And just in regard to whether or not it's overwhelming, I think that goes a little bit back to what we all spoke about before in regard to our passion for this work, which on some level, of course, it's overwhelming. These are people's lives, and people's lives have been dramatically altered, and sometimes they're actually ending. But the other piece of it is just the honor and the privilege of being involved in these kinds of conversations with patients and family. It is privileged work. And I think everybody on our team feels that. And I think you can feel that energy when it's present. And I think the patient can feel it and the family can feel it. So on some level, it is also energizing. And I think that that's an important piece of how we all keep going.
And I mean, but we do worry about burnout. And that's why the team is really important. When we see patients together and we really are somewhat overwhelmed, we can process that and figure out the best strategy. And it's really important that people who do this work have balance in their life and attend and reflect. But it's deeply satisfying, but it's also deeply affecting.
I have a question. Is there an independent body that rates the different types of palliative care and hospice services available in our city?
Gee.
I'm not sure that there's something that rates it. I mean, there are bodies that list, palliative care.
Yeah, I mean, you can get joint commission status for some hospitals, which speaks to the availability of services, but that doesn't necessarily state the quality of services that exist. So I would have to say we're not aware of that particular rating. I wanted to just mention something before. There was a question about accessing a palliative care consult and how often medical professionals aren't really built to refer patients to palliative care. And it's interesting, often medical professionals connote palliative care with end-of-life care and are afraid to give that message to a patient. It's interesting, at MD Anderson Hospital, which is a cancer center, they changed the name from a palliative care service to a supportive oncology service. And when they changed it to supportive oncology, the number of referrals tripled. So the language is important, and
At least for the doctors who are referring.
doctors, and maybe for patients too. But it's an interesting language issue.
I think that we all feel in palliative care that this is part of general medicine care that should be incorporated on an everyday basis. Unfortunately, it's had to be teased out because it didn't exist, and now we're trying to reincorporate it. And we talk about providers at both mid-level, like nurse practitioners and physician assistants and even nurses and social workers, that we should all be doing palliative care. And this is looking at the person as a whole person, including families as a unit, and looking at symptomatology, both physical and emotional. I think it's about timing, right? So a lot of care providers don't have the time, and I think one of our gifts is that we tend to be able to have the time to do this. So
That's a really important point, that we expect the primary care physicians, nurses, and social workers to attend to the palliative care needs of patients. When they can't attend to them properly, they can call us in because we have specialized knowledge, but it should happen as a primary part of whatever health professional you are. And Beth has created actually a training program for nurses called a Nurse Champion, a Palliative Care Champion program for nurses at our hospital and also for social workers at our hospital, so that we're improving the skill set of people on the front lines, because that American medicine has to go in that direction. It's the only way we'll ever offer adequate palliative care, because there's very few of us who do this work.
And we also do a good amount of teaching of young physicians and medical students about what palliative care is and how to do at least basic palliative care. And Beth, when you were just talking about, the everyone should be doing it, I was thinking about the young woman who was there before who said she was a medical student, and I was thinking about how when I teach first-year medical students about what palliative care is, almost all the time someone will raise their hand and say, "Isn't that what all doctors are supposed to be doing?" And and then, as they go further through their training, time or whatever it is doesn't allow for everyone to be doing it as much as would be desirable.
And just to add, I mean, I think when Dr. Adelman was just saying that we're doing these training programs at the nursing, for nurses and for social workers, and I think that the piece is that, the people that are spending the time with the patient are the nursing assistants, the nurses, the social workers, the chaplains that are there. They're spending so much time is giving these providers a voice to feel comfortable to be able to advocate for patients in different ways that maybe weren't acceptable before or were kind of suppressed by hierarchy. So I think it's empowering all of us as providers to make sure that we're respecting patients' wishes, but also giving them a voice maybe that they didn't feel comfortable doing. So that's kind of the philosophy.
Could you address the use or the inclusion of non-traditional medicine in your daily conversation and recommendations, and how much of your counseling is available to patients online?
I mean, the hospital just about maybe 3 years ago has an integrative medicine arm, which is a wonderful piece of that has incorporated where patients and families can go now to explore those options. I think there's a few of us on our team that have special training in certain alternative therapies, and maybe Jean can speak a little bit to what she does and incorporates into her practice and giving to patients and families. But I think that we all believe in it, and we try and explore those options and offer resources. As far as counseling options, I think that we try and provide with social workers, some basic counseling, and we try and incorporate more intense counseling if needed in the inpatient and outpatient setting from our palliative care perspective. But if the family or patients need more, we do a referral process and try and find the best fit for them. I mean, not everybody's receptive to those, so it would have to be someone. But we do try and explore what patients are interested in. And so I don't know, Jean, do you want to talk about that?
I would just say, I mean, as Beth mentioned, and I think that so many of these things are growing, right? What we see as far as an interest and an acceptance of more integrative approaches, it gets bigger every year. Just not big enough yet, right? But within our team, there are a number of us that are trained in different kinds of meditation, guided meditation. One of our holistic nurse practitioners is very, very adept at that. So both she and I at times will use meditations with people that are in pain, going along with the work of the more Western pain medications. But so that's a very important thing. I mean, there are times when meditation is extremely effective. The other practice that I have been using for years is I'm a Reiki practitioner. And so often patients will come in even requesting that. There are 2 of us on our team, and then a number of other chaplains not on our team, but just throughout the hospital are trained in Reiki, which is, for those that don't know, I mean, it's just based on energy and you don't even have to touch, but you can touch the person. And at the very least, it usually helps to relax, and it can also help to reduce pain. And so just in the last 2 days, we accompanied a very young woman who, horrible story, diagnosed 3 months ago, died today. But one of the most important things that we offered to her from the first time we met her in the ER was Reiki. So we do try to incorporate, but again, these are growing parts of healthcare and how we respond.
Hi. This is another, I'm sure, difficult conversation in America and everywhere, but how often, if ever, does organ and tissue donation come up as, part of end-of-life decisions for young people and older people?
It does come up. There are, some patients and families that feel very strongly about it. A lot of times those conversations are actually conversations that happen with the primary medical team that's taking care of the patient in the hospital, more so than with the palliative care team. But if it should come up when we're seeing someone as, something that's important to them, then again, we make sure always to communicate the things that we may have learned about a patient or a family. And I know, sort of tangential to that, many times the young doctors, the interns in the hospital will say to us, "Oh, I'm so glad you, wrote that note about this long conversation you had, because I got to learn so much more about this person than what I already knew." And it opens doors for them to then explore more with the person.
And it's also important, the advanced directives often have people become aware of that, and it's something they want to give. And so, but we can have conversations, but certainly Live On New York is called in to have these conversations at certain particular times, because they are delicate and sensitive as well, conversations.
They did leave some, Live On New York did leave some literature, and there's some copies available on the tables.
You had a question.
Yes, I have one question on, you gave considerable emphasis on coming to understand the patient's wishes. And sometimes, at least in some states, it can openly happen that the patient says, "I want to die. I know it's hopeless, and I see no good purpose served by my suffering and going on." Not in New York, I understand that, so that constrains what you can do. But how do you handle these kinds of situations? First of all, is it a common experience that you have in dealing with patients? And secondly, how do you handle it? How do you communicate that information, which may be useful to the medical team itself? You described changing the treatment that is given depending on how the patient feels about symptoms and so on. So there's obviously some room to maneuver, but I'd be very interested to hear your comment on this issue. Death with dignity or assisted suicide, depending on your point of view.
That's definitely an issue that comes up. I think more than the issue specifically of assisted suicide, which I think it oftentimes is a more outpatient kind of issue, but in the hospital there are times when people will say to us, I've had enough. And in New York State, it is not legal for us to, assist someone in dying. But when someone is expressing that, very often it's tied to symptoms that are not adequately controlled. And so we will really work hard on trying to explore what it is that person is feeling that's making them so uncomfortable that they feel that they can't go on any longer, and try to help address those symptoms. In those cases, there are times when it may be related to pain, it may be related to psychological issues, and we may involve psychiatry, or some of our social workers may do more intensive therapy, or I think with Jean, a lot of times that will be an area to explore, like why someone is feeling that much distress that they want to hasten the time of their death.
And sometimes as well, why don't you say it? Part also, there are times when, Oh, there are times when people are ready to die. You know, they've had enough. And we will listen to that. And maybe instead of aggressive care, we give them a break and listen to them and go into a comfort care and really treat them very aggressively for a symptom that is intolerable. So we have the limits of our laws, but we do listen to as much as we can, because there are times where people are on their deathbed and we want them to go in peace. And so we will treat the symptoms.
And allow other treatments to be taken away or peeled back so that things that might be sustaining them, whether that's giving them more fluids or giving them food that they're not hungry for, artificial feeding, in those sort of situations, you might say, we don't need to do that anymore. We don't need to give you antibiotics anymore if you don't want to take these things that may be prolonging your life. We can withhold or withdraw those kinds of treatments.
So we're called in a lot to discuss those issues and to work with patients and families to make sure their goals of care are heard, and then we do what we can to adhere to the patient's goals.
Short of actually actively hastening their death.
So, there's another question back there.
This is kind of a gray area, I guess, but do you actually have to occupy a hospital bed to be eligible for inpatient palliative care, or can you go home, be in pain, not have the outpatient service, and go into the hospital and get it for the day and not actually overnight at the hospital? Do you know?
It hasn't worked that way. We're usually called in by other services. We are, but on that note, we are trying to integrate into the emergency department so that if people are there in pain and we can treat the pain or understand it better and prevent an admission. This happens, for example, when someone is in hospice and the pain is uncontrolled and they call 911 and they end up in the emergency department. We need to be able to treat their pain effectively, and sometimes the opioid levels are quite high and maybe the emergency department staff is a little uncomfortable with it, but that's an area of important integration for the hospital. So
So it's coming.
I think it's coming.
Okay,
yes.
thank you.
So this is going to be, I think, our last question.
Here again, it's very simplistic. What does opioid mean?
Oh, yeah. Why don't you answer that?
I mean, this is a word that we've incorporated now into our medical language to replace narcotics. So pain medication that is a certain, we call it a scheduled medication that requires practitioners, either nurse practitioners, physician assistants, or physicians that are required to have a special training and also a special code to be able to prescribe the medication. Does that answer? Oh, things like morphine, Dilaudid, oxycodone, OxyContin, Tramadol.
So how does that relate to just prescription drugs? That's an aspect of prescription, or is that given by the doctor in the hospital?
Yeah, no, it's just an aspect of prescription medication. So it can be prescribed in both an outpatient or an inpatient type of setting. That's a good question, though. I'm sorry, we probably should have clarified what opioids were before.
And I want to thank you. You're such an incredibly attentive and wonderful audience. Thank you for the great questions. And I know I speak for the team in thanking you for being here tonight. Thank you.
So I just think it was a real privilege to hear you, and it was just a wonderfully human conversation. So thank you very much.
And thank you, Wendy, for all of your great organization. We really appreciate it, Wendy. Thank you.